Hi, Dr. Peterson here with Regions EMS. One of the primary responsibilities of an EMS medical director is to develop and approve patient care guidelines. Here at the Medical Director's Office, we continually review the scientific literature to ensure that our treatment guidelines represent the best available evidence, and every few years we undertake a comprehensive review and update to our guidelines. Well, it's that time again. I can assure you that this update is much less substantial than our last update in 2014, so no reason to panic. We assembled a group of providers representing all of our partner agencies to provide input and feedback through the guideline development process. Several of the changes were a direct result of suggestions from frontline providers, such as yourself. The first thing you'll notice is a slightly cleaner design. We kept the flowchart style algorithms, but were able to streamline several of the individual guidelines. Each guideline now has a box highlighted in blue, which indicates the starting point for that guideline. Navigation was a concern that we heard loud and clear. The table of contents is now at the very front, and each cross-reference within the guidelines now includes a page number for quick reference. Hopefully, this makes the entire reference easier to use. Starting at the front, several of the policies have been updated, essentially to reflect current practices. The majority of these changes do not affect your frontline day-to-day operations. The biggest change is to the controlled substances policy, which includes our new ordering and auditing process, which many of you are already familiar with. Other recommended policies to review would include the documentation and non-transportation requirements for patients refusing evaluation and transport, such as in third-party caller situations, as well as the transport destinations and care plans policy, which may help provide a decision-making framework in unique situations. Moving on to the actual patient care guidelines, very little has changed. In fact, for those of you who use the pocket reference version of the guidelines, not enough has changed to justify printing a new version. So what actually changed? Well, the biggest change is that we removed dopamine from the medication list. Dopamine is a medication that rarely gets used, requires manual calculations which are prone to error, and is not actually the right medication to use as a first-line vasopressor for shock. For various reasons, it has remained in our EMS arsenal, but is really not the right tool for the job. In its place, we are introducing push-dose epinephrine. This is epinephrine diluted to 1 to 100,000 and given in small doses as an IV push medication. It is easy to make and even easier to dose. Adults get 0.5 to 2 mLs every 3 to 5 minutes, and kids get 0.1 mLs per kilogram every 3 to 5 minutes. This ensures that you know exactly how much medication has been given to your patient and overcomes the major risks of using epi-drips without an IV pump. You should consider using push-dose epi for hypotension after a resuscitated arrest, hypotension after an RSI procedure, or other shock states after an adequate fluid bolus has been given. Another optional medication has been added, which your agency may or may not choose to carry. Methylprednisolone, or Solumedrol, is a steroid medication used to reduce inflammation and suppress the immune system. The two indications for this medication include moderate to severe allergic reactions and wheezing due to asthma or COPD. You will not see an immediate improvement, but in some cases, if it is given early enough in the treatment course, it may help to prevent the need for hospital admission after several hours of observation in an emergency department. The standard adult dose is 1 vial, or 125 milligrams, and for kids, it is 2 milligrams per kilogram. The vial must be reconstituted, but is typically packaged as a single unit that is easy to mix. Other changes include an increase in the allowed ketamine dose for severe pain after adequate opioid medication has been given, updates to the list of obvious death criteria for which resuscitation attempts should not be started or continued, and finally, updates to the cardiac arrest checklist. These will be emphasized in upcoming training as we work to implement a more formal incident command structure for cardiac arrest situations. The final update I would like to highlight is the trauma destination plan found in the reference section at the back of the guidelines. There have been some changes to the trauma designation level of several local hospitals recently. After reviewing the hospital requirements for each level of designation, as well as the national and state evidence-based recommendations for the triage and transport of trauma patients, we developed a trauma destination plan that lays out specific criteria which should guide you in your transport decisions. Any patient who meets any one of the physiologic or anatomic criteria in the Tier 1 trauma section should be transported to a Level 1 trauma center and likely will meet trauma team activation criteria. These patients have injuries which will require specialists that are not available at other facilities. The Tier 2 section contains a list of mechanism of injury criteria and special circumstances which would recommend transport to a Level 3 or higher trauma center. In the East Metro, Lakeview Hospital in Stillwater and United Hospital are both designated as Level 3 trauma centers. Fairview University is designated as a Level 2 trauma center, and of course Regions Hospital is the Level 1 adult and pediatric trauma center. The rest of the hospitals in the East Metro are Level 4 trauma centers and may not be appropriate for many of the trauma patients we treat and transport. More to come on this in a future education update. Well, that sums up all of the major changes for this update. As always, we welcome feedback on our patient care guidelines and will continually review them as new evidence becomes available. We are here to support you and make sure that together we are providing the highest quality of care to all of our patients. Thanks for watching, and maybe we'll see you on the next big one.